Well, I think we'll move on to Dr. Stone's, to Lael's presentation.
So it's my pleasure to talk about some of what's new in MR imaging in MS that we learned about in the ACTRIMS meeting. And one of the things that when I went around and I asked a few people at the meeting what they found most interesting was some work done by a group in British Columbia led by Cornelia Laule, which looked at myelin water. And I've entitled this Measuring Myelin Repair. One of the things that is exciting to us in the MS field, or perhaps keeps us going, is the idea that perhaps at the point when we can actually slow or stop the disease process of multiple sclerosis, we may at some point be looking at remyelination compounds. And we are at this time trying to get to the point where we really can look at potential remyelination compounds. So conventional MRI tracking that we have done with other sorts of disease-modifying agents is really has really poor pathological specificity and sensitivity for non-lesional disease. So this is going to be particularly problematic when we're looking at remyelination agents. So the lack of these outcome measures for myelin repair has made it difficult to know if the experimental agents are actually effective. So Dr. Laule gave at least one presentation, and then there were a couple of other abstracts, and she talked about some of the potential measures that we could use in imaging. One of them was diffusion tensor imaging, which looks at water flow. Another was magnetization transfer ratio, which looks at bound and unbound water, and actually may have some advantages in terms of the sensitivity, also being able to look at gray matter remyelination, looking at MRS, which is spectroscopy, looking at the chemical components. She talked a lot about her particular area, which was myelin water imaging, and also PET. One of the disadvantages with PET is obviously the lack of availability and the ionizing radiation that the subjects would receive. However, this is an interesting area. So all of those have limitations, but her point was that multi-echo T2-based myelin water imaging may be the best and maybe the almost ready to be put into clinical trials. So what the myelin water imaging measures is the water trapped within myelin bilayers. And it's specific for myelin, but the water component exchange may be a confounder. And now recent advances enable the whole brain to be covered. So I think that that's very exciting. And then her group also put together a couple of abstracts. One of them was showing, not the one that is on this current slide, but there was also a presentation which talked about the fact that this could be taken in a multi-center trial. We have a lot of trouble if we have a fancy, wonderful measure and it can be used only at one site, but they are beginning to use this myelin water measurements at multiple other sites. So she has shown in her group cross-sectional studies with decreased myelin water fraction in normal appearing white matter. And the myelin water fraction has previously been found to be stable over 6 months in at least some patients, but it hasn't really been carried over time. So they took a group of 11 relapsing remitting patients who were followed over 5 years. Their baseline age, relatively youngish, 28 to 35 years, disease duration, pretty broad duration of disease, and an EDSS of 1 to 6, and 4 healthy controls. They scanned them at baseline and long-term follow-up, average of 4.8 years, with a range of 3.2 to 5.8 years at 3 Tesla. So this was at a relatively high, but not the ultra-high field. And the mean normal appearing white matter myelin water fraction significantly decreased at long-term follow-up. And you can see the numbers on the slide. So it was interesting that there was a decrease in the myelin water fraction showing ongoing demyelination within the normal appearing white matter. So I think that this is a potential outcome measure that might be applicable in multi-center trials and might allow for follow-up over time. So I think that's something we're going to be hearing more about, particularly as we have more potential agents to look at remyelination. So I had a couple of examples of the higher field magnet, both out of Danny Reich's group, which is at the NINDS, and also in coordination with Johns Hopkins, because we've been very interested to see whether higher field magnets, which give us much prettier pictures, will actually produce anything that is more usable in terms of clinical relevance. So one of the two examples that I have is on the leptomeningeal inflammation. And we have seen from previous studies that leptomeningeal inflammation is associated with meningeal vessels, and that's been described and it has been seen pathologically in multiple sclerosis. So they have reported that on a 3T MRI magnet, 25% of 300 patients have shown leptomeningeal enhancement, which they call LME. It's interesting that it was in the relapsing remitting, it was only about 20%, whereas this is something that's actually found in about 33% of progressive MS patients. So we're not saying that this is something that you're going to see in all patients, but it's a very interesting sort of thing because we're very used to thinking about blood-brain barrier in multiple sclerosis, and this is really evidence of blood CSF breakdown potentially, which is another sort of interesting side piece. So they took these patients up, they took 7 MS patients who were studied at 7T, and the leptomeningeal enhancement was closely related to one or more meningeal vessels after gadolinium enhancement, and they saw focal bright signal strictly adjacent to a vessel. So that's, again, looking at this whole sort of idea of the blood CSF breakdown, and that it does seem to be at least present in a significant fraction of progressive patients. And that was one example of our way to kind of get from histopathology to MRI. So they also were able to examine some of these patients at autopsy, and they were able to look at the focal leptomeningeal and perivascular inflammation was found in areas corresponding to the LME on the MRI. So this is a very interesting imaging pathological correlative finding, and it's compatible with leakage of gadolinium from the vessel and subsequent local flow within the CSF near the vessel. Interestingly enough, the group at Hopkins is actually looking at using rituximab intrathecally, which again would be sort of getting at this whole idea of CSF and getting into the CSF and perhaps being able to get at some of these patients that we've not been able to treat in other ways. And here's an example of the imaging. I don't know if you can see, there's a red arrow for the leptomeningeal enhancement at 3T on the first image. The second image shows the 7T. So interestingly enough, the 7T didn't seem to give that much more numbers of the leptomeningeal enhancement, but you can certainly see it a little bit better. Now, the other study at high field that I thought was interesting was looking at PML. And we are now sort of struggling with the idea that we do have to be concerned about surveillance for PML, and the potential development of PML and the early detection is extraordinarily important. We're feeling that a combination of FLAIR and diffusion-weighted imaging may be the way to go in terms of surveillance, but there's a lot more that we want to understand. And in talking to a number of people, we found that this was a very interesting finding on high field magnets in patients who had PML. So what Danny Reich's group did is they looked at 12 patients who already had PML, 5 of whom were MS patients, 3 with HIV, 2 had chronic leukemia, 1 lymphoma, and 1 with chronically low CD4 counts. And in all of those patients, the PML lesions were clearly visible as asymmetrical white matter hyperintensities on T2 star weighted images with a starkly T2 star hypo-intense band, and it was also noted adjacent to the PML lesions. So this band, which I'll show you in the subsequent slides, was never seen in association with pre-existing MS lesions. So what they found, unfortunately, they found that this band increased over the course of time, and using the co-registered T1 weighted images, the band was found to involve subcortical regions in the deeper layers of the cortex. They did do a post-mortem case in an HIV patient, and it suggested that this line was iron deposition. So I thought those were interesting from a high field standpoint. Here are a few examples. The red arrow shows the red band, and then we're going to get a little expansion here. And we can see there the dark band there on the T2 star epi and the MP RAGE images. So finally, I wanted to kind of talk a little bit about gray matter changes. We've talked about MS as a white matter disease for years and years. We're finding that gray matter actually is affected as well, and particularly the thalamus. And Dr. Motl's group at University of Illinois did some interesting work that reminded us of this, and I thought was an interesting piece. He reminded us that the thalamus and the basal ganglia have been associated with clinical manifestations in MS. We saw this in a number of presentations on cognition, fatigue, and other motor manifestations. Something also to remember is that subcortical gray matter atrophy, thalamus, basal ganglia nuclei, is associated with walking difficulty in healthy adults. And one of the things that they were interested in looking at is with exercise training or these and improvement in walking, are these peripherally mediated or centrally mediated mechanisms. So as an initial way to kind of get at this, they took a group of 63 patients, mixed types of multiple sclerosis, age 50, age mean of 50 with a standard deviation of 9.2 years, imaged at 3T. They did this, the SDMT and the 6-minute walk, and they looked at the basal ganglia nuclei and thalamus, and they found that those were associated with walking performance on the 6-minute walk, but only the pallidum explained unique variance. That actually is a new finding, which is of interest. And they sort of had an internal control to that finding where they were able to replicate the second bullet point, or the third bullet point here, that the thalamus and basal ganglia nuclei were associated with cognitive performance on the SDMT, but only the thalamus explained unique variance in cognitive performance. So one of the things that I think we're going to be reminded of over and over again is the involvement of gray matter in multiple sclerosis, and this interesting connection between walking and cognitive function. And it will be interesting to see if we can be using gray matter changes in clinical trials, and if there may be some feedback in exercise training and walking from a cognitive and overall functional status. So these were the ones that I looked at from this meeting.
Thanks, Lael. Melissa, did you have any questions for?
I do. As you mentioned, Lael, leptomeningeal enhancement on 3T imaging is a very new thing for many clinicians. For a busy clinician observing LME in a multiple sclerosis patient, what do you advise? Should they work the patient up further? Should they just follow the patient with imaging, or just ignore it?
Well, I think we have to recognize that it's an interesting finding. It's not a very common finding. It's certainly more common in progressive patients. So I think we have to distinguish between pachymeningitis or overall meningeal enhancement and these little very small areas. So I guess I think it may be one of those things when you're not looking for something, you don't see it, and then when you start looking for it, we may start seeing it. And we're not sure what it means pathophysiologically, but it could be an interesting window into, again, sort of how the blood and the CSF may be interacting in MS.
Thank you.
And Dean, did you have any questions for Lael?
Yes, I do. That was a very nice summary. I'm interested in the 7T, the high field magnets, and your perspectives on the discovery so far. What's been surprising, and what hasn't turned out to be so successful as we thought it might be with the 7T procedures?
Well, I think that like many of these imaging techniques, we get very excited and then it takes a long time to translate them into the clinical realm. A lot of technical sort of software issues that have to go on. But what's most interesting to me is that some of the histopathology that we're seeing from our autopsy and biopsy cases, which at your institution you're well familiar with, some of these we can actually get some correlation in 7T and go back and forth. And I think that will allow us to, as they say, interrogate the pathophysiology of the disease in a more interesting and exciting manner.
Today we're talking about MS research from the ACTRIMS meeting of 2014 in Boston. Very pleased to have Dr. Richard Ransohoff with me, who's from the Neuroinflammation Research Center at the Cleveland Clinic. He's a staff neurologist, but even more importantly, is a world-famous researcher in basic mechanisms of multiple sclerosis. Dr. Ransohoff is going to talk to us about basic sciences highlights from the ACTRIMS meeting. Dr. Ransohoff.
Thanks, Alex. Thank you for your interest. Let's go ahead and get started. First, I want to talk about a study called In Vivo 7T MRI Characterization of Leptomeningeal Enhancement in Multiple Sclerosis. This comes from Danny Reich and his group at the NINDS in Bethesda, Maryland, the internal research arm of the NIH. They had a companion abstract that I also want to mention called Is Focal Leptomeningeal Enhancement an In Vivo Imaging Biomarker for Meningeal Inflammation? So here's the background. Meningeal inflammatory infiltrates have been described in both autopsy and biopsy tissues from MS cases, so end-stage cases and cases that were in the process of being diagnosed, early-stage cases. Furthermore, B cells, which sort of live in these organized meningeal infiltrates, are proposed to be the source of oligoclonal bands. And since those are present in almost every MS patient, this may be relevant for a great wide variety of patients. So what did they do? They took 7 MS patients in whom they had previously shown leptomeningeal enhancing foci on careful 3T imaging. And later on, they didn't specify the time frame, they did 7T imaging, and they used 3D reconstructions of whole brain T2 flare, T1 MPRAGE, T2 star, and they used T2 star to demonstrate contrast enhancement. In the other study, there were 2 deceased MS patients who had post-mortem 7T MRI that was correlated both to pre-mortem 3T MRI, which had shown leptomeningeal enhancing foci, and also to the neuropathological characteristics that were found in the autopsy tissues. Here's what they found. The 7T MRI in those 7 living MS patients still showed leptomeningeal enhancing foci and demonstrated that they were localized around Peel vessels, which could easily be seen at the 7T resolution. In the postmortem study, 7T MRI showed, in correlation with neuropathology, that these foci are real. They are composed of inflammatory cells clustered around Peel vessels. What does it all mean? Well, first of all, it tells us that the line of research over about the last 10 years demonstrating, using neuropathology, that leptomeningeal infiltrates are very common in MS patients, that these are real and that they happen during life and early during life. Furthermore, these foci are present both early in disease and in advanced secondary progressive MS cases. Thinking about these autopsy cases, even in advanced cases, because they showed with the 3T MRI that there were leptomeningeal foci during life, this demonstrates that there are contrast-enhancing peel infiltrates that are active and sort of communicating between the peripheral immune system and the CNS even very late in MS. So where do we go from here? Well, first of all, is there any relationship between these foci and clinical progression? That's obviously most important. Secondly, is there any relationship that can be demonstrated between these foci of inflammation in the leptomeninges and the underlying cortex? In autopsy specimens, they are very commonly related to areas of cortical demyelination. This was not detected in the 7T MRI study, and so far it isn't reliably detectable by conventional MRI. That's a problem that really does need to be solved. And finally, of course, we need to know, can our present therapeutics or anything in development affect the presence of these foci? Are they a real legitimate target for intervention? Now that we can see them, we can begin to ask those questions. Okay, let's move on to another topic. This is an abstract called Neural Precursors Derived from Mouse iPS Cells Extensively Remyelinate the Demyelinated Central Nervous System. This comes from Anne Baron van Everkoren and her group at INSERM in Paris. So, as a background statement, iPS cells, which have garnered a Nobel Prize already, are stem cell-like, and in theory, they can differentiate into any cell type, just like embryonic stem cells can. But an advantage over embryonic or EPS stem cells is that iPS cells can be derived from patient fibroblasts, which offers a possibility for personalized stem cell therapy. A really amazing thing to consider. So what this group did in the present study is generate iPS cells from mouse fibroblasts. They differentiated them in vitro into neural precursors, and then they injected those neural precursors derived from the iPS cells into the CNS of immunodeficient mice, so they wouldn't have any problem with immune rejection. And these mice had received a focal chemical demyelinating lesion, so they knew where to look for any evidence of repair. By 10 weeks after the injection, the iPS cells survived. They migrated to the demyelinated lesion. They differentiated into oligodendrocytes and repaired the damaged myelin. Although the iPS cells could potentially give rise to teratomas, this is always a worry when stem cells are injected into tissue, no tumor formation was observed in these studies. Furthermore, the iPS cells did just as well as mouse embryonic pluripotent stem cells in these experiments. So these results provide a very nice proof of principle that personalized stem cell therapy for demyelination is worth pursuing. The last topic I'd like to discuss with you is entitled Leptin and Other Adipokines in EAE and Multiple Sclerosis. EAE, as you know, is experimental autoimmune encephalomyelitis. That's an inflammatory model, often done in mice, for the disease multiple sclerosis. This work comes from Ann Cross, a neurologist at Washington University in St. Louis. So the risk of MS, as a background statement, is associated with genetic variants and environmental factors. Recently, childhood obesity was identified as an important environmental risk factor for later development of MS. So why should that be? It turns out that there are substances called adipokines, which are inflammatory cytokines produced in adipose tissue. The adipokines include some relatively more familiar mediators like interleukin-6, as well as somewhat less common, at least in the neurologic lingo, mediators such as adiponectin, resistin, and leptin. You can see they're not that familiar, even to me. And again, as a background statement, if you take mice and reduce their adipose tissue by fasting them, they develop less severe EAE when they're immunized later on. So this study focuses on leptin, which is an inflammatory adipokine, and adiponectin, which has anti-inflammatory properties. Mice with a genetic deletion of leptin, which you would call leptin knockout mice, are relatively resistant even to develop EAE. Adiponectin knockout mice show the opposite face. These mice get worse EAE, and it turns out that T cells from adiponectin knockout mice can be injected into regular mice and act very aggressively. They cause severe EAE and make very high levels of inflammatory cytokines. So based on studying this leptin-adiponectin balance in EAE, and based on their studies fasting mice, and then showing that those mice had milder EAE, the investigators at WashU plan a small pilot study of caloric restriction in MS. Stay tuned for this one. It could be very interesting.
Thanks, Richard, for your comments. Those were great. I had a couple follow-up questions for you, actually an observation. So we had recently, one of our residents looked at patients with MS who had had gastric bypass surgery. And we had 24 patients who had that. And we did a case control with patients with similar disability and age who had not had gastric bypass surgery. And interestingly, in the patients who had the bypass surgery, we found that their walking scores, their timed 25-foot walking scores, had improved. Now, we just assumed that was all the weight, but this paper you presented kind of suggests maybe there was more of a biological mechanism. How might we prospectively look at that in the MS population who undergoes bypass surgery?
That's fascinating. It shows how much is going on at the Mellen Center that I don't know about. There is, as you know, an awful lot of adverse health consequence to obesity. And it has been a very intense subject of research in recent years. So I think there are some guidelines that might help you in pursuing this. I think it would be particularly interesting to know what happens to levels, for example, of adiponectin, which turns out to be an incredibly interesting and potent mediator of many processes throughout the body, and then also what happens to leptin in these individuals.
Very good. And the other question was about Dr. Cross's work. You know, there's a lot of interest in remyelination strategies in what we can do to improve that component of this disease. But how will we measure remyelination in the clinic? I mean, what do you think the strategy will be going forward to see how well we've done in remyelinating in an individual patient?
Right. So that is the big question. It is difficult to image remyelination, but that clearly is what we must do. And as a non-imager, all I can do is tell you what I've read or heard about. What I understand is that there are magnetization transfer ratio approaches to looking at myelin as an indicator of tissue integrity, which is what MTR is, and that these may be productive for measuring remyelination. The other way to go after the question is to use PET imaging. We know that there are dyes, such as Luxol Fast Blue, which bind to myelin. It has been very productive to use dyes that bind to amyloid for amyloid imaging. And by analogy, there's some very impressive early work going on using the myelin binding dyes to try to develop PET ligands that will allow PET imaging for remyelination.
Very good. Well, thanks again for your comments.
Thank you. It's a pleasure to be here.
So I'll be talking a bit about some of the other abstracts from the ACTRIMS meeting and really things that maybe had a take-home point for busy clinicians. And the first one was on dietary patterns. And I think this is very interesting work. We all get asked by our patients about diet. It's one of the first questions they ask us. And so this really looked at dietary patterns that didn't seem to be associated with risk of MS. And this was from the Brigham and Women's Hospital, Dr. Rothstein. And they used data from the Nurses' Health Study, Nurses' Health Study 2, very large study with over 185,000 nurses. And the nurses had completed semi-quantitative food frequency questionnaires every 4 years for many years. They had 480 cases of MS between 2004 and 2009 in this study population. What was interesting is none of the dietary patterns measured correlated with MS onset. So Western diet, Mediterranean diet, and a prudent diet didn't really have any significant relationship with MS. So what it says to us is particular diets don't seem to be causative or change the epidemiology of MS. It doesn't tell us anything about diet modification in patients with established MS, but really says diet per se is not a critical factor, at least as far as they could measure in this study. Your patients will continue to ask about diet. I think we say at the Mellen Center, a heart-healthy diet is good for them, and we have good evidence that general health measures are important, but no specific diet that we can tell people to do. Changing gears a little bit, a very interesting PET imaging study from the Imaging Center at Mass General, Dr. Gianni. They looked at PBR28 MR PET imaging and looked at inflammatory activity in patients with PET imaging. And they used this marker that looks at macrophage activation. And these are patients who didn't have any other imaging correlative inflammation at the time. They weren't having gadolinium enhancement or a lot of MRI new lesion appearance. So one of the things we may see is that later in MS, macrophage activation may contribute to continued disease activity. And standard imaging may not show that. So maybe this is a window into some of the inflammatory activity later in disease. We know that active macrophages and microglia upregulate expression of a translocator protein, TSPO. And this can actually be imaged using a ligand. So this is what they utilized for this PET imaging study. What they found was in patients there was a significant increase in uptake in both the normal appearing white matter and in cortical sulci using this technique. And this actually correlates very well with areas with the most activity at autopsy for demyelination. So it was a nice correlate between the in vivo and the imaging modality. And so perhaps some of the late component neuroinflammation will be imageable and we'll be able to target some treatments in this population. And we know that you can only evaluate what you can measure. And new measurements will really probably help us evaluate the hidden parts of the MS puzzle. So I think this may be very beneficial going forward in terms of study design and analysis of what are we doing with inflammation in this population. So the question would be, would this influence your current practice? Probably not in our practice, just because we don't quite know what to do with this. But I think what it may influence is some study design and also continue to look for anti-inflammatory measures in the population later in disease. This was quite a different study, but I thought was of interest. This was a study from Dr. Sosnoff and his colleagues at Univ of Illinois at Urbana. And they just looked at reliability of a clinically feasible gait analysis in MS. And we've been doing a number of gait studies at our center, as have many centers. But what they pointed out was gait analysis is becoming much more important in the long-term follow-up of MS patients. Both the 25-foot timed walk, 6-minute walk, a variety of other gait analyses, in addition to more specific gait analysis. It turns out also gait complaints are often the most significant issue for MS patients and the thing that stops them working and stops them moving. So it'd be very helpful to have a reliable gait assessment tool, both for disease-modifying therapy management to see if these agents are helping, as well as the use of medications such as extended-release delfampridine. They looked at the rate of reliability of the gait-right system, which is a readily available system in 86 ambulatory MS patients. What they looked at was gait velocity, step time, and cadence. And they also saw that measures actually reflected a slight but significant reduction in gait speed over 6 months in this population. So they showed that we could use these measures in a pretty reliable fashion. So we know that quantitating the neurological exam using newer techniques will show us things we couldn't see before. And in fact, there probably will be an app for that at some point to measure gait in patients. So stay tuned for that one. There were a number of studies that were presented with phase 2 or phase 3 data, and one that was interesting was diclizumab HYP and a presentation of that versus interferon beta 1A. And Dr. Kapos presented for the group. So this is a humanized IgG1 monoclonal antibody specific for CD25, and it inhibits activation of T-cell response. And so these were the primary results of a phase 3 trial. There have been a number of phase 2 trials. There's a large phase 3 trial in MS relapsing patients. They randomized to diclizumab HYP 150 milligrams sub-Q every 4 weeks versus the standard interferon beta 1A 30 micrograms weekly. And this is following on to about 15 years of study with this and related agents. The results showed a reduction in annualized relapse rate compared to the active comparator in about 1,000 participants per arm. This is a significant benefit. And also significant results on MRI-defined lesions at week 96. So what we're seeing is, again, a study that shows benefit compared to a known agent which has activity in the disease. I think what we're going to see is more newer generation meds for MS coming to market, and we'll have to assess issues such as relative efficacy, risk, and cost, and life is going to continue to be a bit more complicated for us. This will be one of the agents that we probably will be looking at in the future. Finally, I thought we would bring in recent revisions of the classification scheme, which we've had since 1999, and Dr. Lublin and his team looked at these and got published in Neurology this year. And I think this does change our thinking a little bit in terms of how we classify patients, what we do with them. So one of the things they included was a clinically isolated syndrome category, which had not been present in the 99 revisions. And these are patients who don't meet the international classification of MS, but have had a single episode and have some other biomarker that's consistent with demyelination. They didn't feel there was enough data to include radiologically isolated syndromes as an MS subtype at this time, and I'm sure that will be continued to be looked at as there's more epidemiological data. What I think was more significant was the change in the progressive group. They dropped the progressive relapsing group, which most of us rarely, if ever, see patients who fit an initial progressive course and then later relapses. So they got rid of that, and they kept the primary progressive and secondary progressive forms, but they added 2 qualifiers. And one of them is active. That is patients who either have clinical relapses in the present time or MRI activity. And then a progressive qualifier. These are patients clinically gradually worsening over the past year. And I hope you can see this. This slide's a little detailed, but this looks at the old classification, the new classification. And the key thing here is that progressive disease still has primary progressive and secondary progressive, but now we add these 2 qualifiers. So this may be helpful for being more specific about where the patient is now and what we may be doing with them at the present time. So that seemed to be a useful change to our classification. So that's my comments for today, so thank you.
Alex, thank you very much for an excellent summary of a number of topics. I do have a follow-up question for you. If we can see inflammatory changes in MS patients that we previously thought had a neurodegenerative picture completely, how does this change your practice?
Yeah, so I think the interesting thing about that is that we've really had this paradigm of early inflammation, late neurodegeneration. We've been saying this for a number of years. I think what this reminds us is that inflammation is going to be there throughout the course of the disease to autopsy. And we may well need to think of different ways to treat the inflammation as well as looking at neuroprotective and neurorestorative strategies in that population.
So Alex, the revisions to the MS disease classifications seems to establish 2 different axes to consider patients. One in terms of their active inflammation, are they having relapses or new lesions? And then another axis of, are they having progression? Are they having little by little progression of their disability outside of clinical relapses? So what implication does that have when we take care of patients? How do we bring that back into the clinic?
Yeah, I think it's really true that changes our perspective somewhat. I think what we've done at the Mellen Center, and I'm sure other centers, we really look at activity in our patient population no matter what their classification is. Even if we call them primary progressive, younger patients who continue to have MRI new lesion activity, we really think of them in the same way we think of relapsing disease, and we have a more active approach to their treatment. And so I think by putting the active label onto things, it gives us a sense of, well, they're still going on, there's still things happening. We need to address that situation no matter what the classification scheme. Well, I want to thank our speakers for a really great set of talks. I want to thank you for your attention, and I want to make sure that you do your CME credit and have a great day.